Recognize the gentleman from Illinois, Mr. Hultgren, 5 minutes.
Thank you, Mr. Chairman. Thank you all very much. A question for all of you. Interoperability, can't speak this morning, is critical to realizing the many potential benefits for health information technology. So far, the federal government, I know, has spent approximately $2 billion in appropriated funds for HIT infrastructure and $7 billion in mandatory incentive payments for HIT adoption. Wondered if each of you could give thoughts, given this investment, have we made appropriate progress on interoperability, and why have we or why have we not made the progress that you all think we should?
I believe that we have made substantial progress on both the adoption and the meaningful use of electronic health records, which includes the interoperability. And this is a long road. As Mark pointed out, these are complex. It's much more complex than saying 4 feet, 8.5 inches shall be the width of the railway gauge, which the U.S. Congress did in 1853. These are quite complex, but I think we have a roadmap, and we have, through meaningful use, a phased approach to being able to bring the whole country, bring the floor up, and create that infrastructure in stage after stage after stage to help increase that journey towards interoperability.
I'd certainly like to agree with my good friend and colleague, Dr. Mostashari, about this. I think we've made substantial progress. NIST has a long history of working on both conformity assessment and also interoperability. And I think the steps that we're taking, and particularly the emphasis on this phased approach that allows us to sort of bring the community along in an aggressive but achievable manner, is absolutely essential to doing this.
Yes, I believe meaningful use has made good progress forward toward the exchange of information and the ability to use it, between organizations. Although it was 4 feet 8 inches for the rail gauges, and that is pretty simple, this is incredibly complex, and therefore interoperability is way more complex than the rail system, and it needs to be taken care of. So I agree with what we're doing around meaningful use, because we have an infrastructure we need to leverage, and we are providing better care, I believe, because of the efforts that are happening. But I still would stand on the fact we need to define a core set of standards that would allow for true interoperability, because the way we're saying interoperability right now, what's really happening is information exchange. Interoperability to me is far deeper, with a far greater capability to save lives and money.
We would also agree that substantial progress has been made, and we certainly agree that meaningful use stage 1 began the proliferation of adoption of electronic health records, and without robust standards for interoperability, the spread of electronic health records will be stifled or limited. We encourage HHS to adopt standards that would support the clinical needs of coordinated care, such as requirements for accountable care organizations, medical homes, and hospital readmission programs. Lastly, I would observe that occasionally federal programs and program rules are not aligned. Providers must comply with different standards for different programs, which make them less attractive. We're pleased to see HHS proposing alignment of rules across meaningful use, accountable care organizations, physician quality reporting, and medical homes.
And yes, I'm going to agree also. But with that, I'm going to tell you some data that I personally collected on a research study at a hospital in San Diego. So I look at interoperability not only across organizations, but within organizations. In this particular hospital, it had been digital for decades. The emergency department had one system, critical care had one system, women's services had another, pharmacy was on another, and on and on and on. And so this is, yes, it was the railroad gauge, absolutely. So each group of practitioners had the best system for them, but they couldn't share easily information across systems. We implemented and integrated, I wouldn't call it interoperable because it doesn't go across organizations except within our healthcare system. And when in this research study, when I surveyed the nurses on the use of the system before we went live with the integrated one, and then 1 year after implementation with the one system, or with the sharing of the information, that they clearly were using the new system much more. They were accessing it for information, for patient data, for patient engagement. I then interviewed the nurses 1 year after to find out, what did the transition go like? How was the system? What were the changes they found? And without a doubt, the nurses resoundingly said that they were able to provide better care because they had all of the information in front of them. They had the emergency department information in front of them that with the click of a button, they would be able to look up past hospitalizations. So we've improved care in this one organization where they can look at the physician office patient episode, they can look at previous hospitalizations, they can look at the information from throughout that hospitalization. Yet, if that same patient goes to another hospital within our community, that information is not available. But I will also compliment ONC because San Diego is fortunate enough to be one of the beacon communities, and so money has been invested so that in San Diego we can have that same type of sharing of information, not only within Sharp Healthcare, but we can have it throughout San Diego.
Thanks. I see my time has expired. I yield back. Thank you.